This week on the Wheelhouse. Healthcare. How affordable is insurance under the Affordable Care Act? For Connecticut Public, I'm Frankie Graziano. This is the Wheelhouse. It's the show that brings politics to the people. We got your weekly dose of politics in Connecticut and beyond right here. Will they or won't they cut federal health care coverage? It's a question the Trump administration has dealt with going all the way back to 2016 and candidate Trump 1.0. And we all remember concepts of a plan back in 24, right? We all remember that. As healthcare customers still grapple with affordability questions today, studies show that Americans are paying more for healthcare premiums. This hour, we'll talk to a local reporter about the cost for people in Connecticut. But first, we'll dive right into federal healthcare policy with somebody from a top health policy watcher, KFF Health News. Julie Appleby is KFF Health News senior correspondent. Julie, thank you so much for joining us on the Wheelhouse.
Thanks for having me.
So glad to have you. Can't wait to talk to you here on the show. Just want to invite folks to give us a call. We'll take them later on in the show, 888-720-9677. Hey, Julie, we're hearing a lot about the rising costs of healthcare for people who buy coverage through the Affordable Care Act exchange. Why is this year such a pivotal moment? What's changing?
You know, it was kind of a double whammy this year. So first of all, we had about an average 20% increase in the Affordable Care Act premiums, okay? And then also, remember end of last year, there was a lot of debate over these things called enhanced subsidies, and Congress didn't act to extend them. So the subsidies, the enhanced part went away, so people's subsidies became less generous. So when you add all that stuff together, people are paying on average about 58% more for their Affordable Care Act coverage this year compared with last year. So that's a big chunk of change for a lot of people.
Hey, before we go further, this is going to be a question for the super uninitiated. So pardon me for the really simple question here, but it does confuse, I guess, some people. Are Obamacare and Affordable Care Act the exact same thing? Is Obamacare still a thing?
Yeah, you know what? It got that moniker. It is the Affordable Care Act, and people started calling it Obamacare because it did pass Congress, and he signed it into law during his term. So they're interchangeable. People use them either way.
The end of last year, there was a political fight, as you were talking about, over the future of enhanced premium tax credits that have helped many Affordable Care Act enrollees get coverage and afford it. The fight culminated in a government shutdown, the longest in U.S. history. Remind us what happened ultimately. Can people still access those subsidies we're talking about?
Yeah, that's a really good question. The subsidies themselves did not go away. They just became less generous. So let's go back in time a little bit. It was during COVID. They passed these enhanced subsidies. They were always meant to expire, but they were extended once, and then they were due to expire at the end of last year in Congress. As you mentioned, we saw the shutdown over this debate over whether or not to extend them. So they still exist, but the difference now is that people get less, and they have to spend more of their own household income toward the premium before the subsidies kick in. And remember, there's a whole group of people now who actually did get cut off from subsidies, and those are people who earn more than 4 times the federal poverty rate. So those folks don't get any subsidies at all. So they're the ones seeing the biggest increase in the amount of what they pay this year. But everybody else is paying a little bit more because their subsidies are smaller and because premiums went up.
By now, can we gather what the current administration's approach is to the Affordable Care Act?
You know, it's done a number of things. So we've seen Congress pass the One Big Beautiful Bill, which had some things in there that affected the Affordable Care Act. And then the administration has recently signed a final rule for 2027. It's the Affordable Care Act. It incorporates a number of those things. So what am I talking about? The administration has made fraud and improper enrollments a big part of their discussion about the Affordable Care Act. And some policy folks, we can talk about this later, debate some of, what all that is. But at any rate, they have set some new rules for next year that are going to increase income verification requirements on some people. It's going to it already got rid of what the special enrollment period for low income people that essentially allowed low income people to kind of sign up year round. So they got rid of that. And there's a number of other things that are in the rule for next year, including, interestingly, higher deductibles in bronze plans and then eventually in these plans called catastrophic plans. And that's interesting because the administration said that'll lower premiums, and people are worried about premiums, but a lot of polls show that people are also really worried about what are called out-of-pocket costs. And these are the amounts you've got to pay when you go to the doctor or the hospital. There's an out-of-pocket maximum for the year, and the deductible is part of it. You've got to pay a deductible right before your insurance fully kicks in. So the Trump administration has sort of doubled down on that and said, well, we want to offer these plans with lower premiums, but we're going to allow insurers to increase the deductibles.
Beyond the debate over subsidies, our lawmakers, and I guess I'm talking about all lawmakers, not just the ones in majority and not just federal officials in the Trump administration, is there broader reforms that are being discussed? Are we having incremental change? Are we having any chance at something that's transformational? What's your thought there?
So I think the broader picture is healthcare costs in general, not just the Affordable Care Act, right? Because we're seeing employer costs go up too. There was a report out just recently from PwC, the consulting firm, that showed about a 9% increase this year and next year as well in what it costs to cover somebody in their jobs. And that's already a big chunk of change for most employers. I think it averages close to like $27,000 a year for family coverage in an employer plan. So when they're looking, when lawmakers and policymakers are looking at solutions to this, sometimes they're looking at creating situations that they can control what is being paid. So health spending incorporates that. So, for example, hospital costs, right? Hospital costs are a big chunk of what we spend money on. It's like 31% of healthcare spending goes to hospitals. Physician services comes in at like 21%. So there are some places that are looking at, hey, maybe we should cap some hospital fees. So my colleagues recently wrote a story about Indiana, and they've got an interesting program. It's a GOP controlled state, and they are actually trying to set some price controls on hospitals, telling them they've got to stay below a certain limit. Otherwise, they might eventually lose their nonprofit status. And a couple other states are doing things like that. So there are some things on the margins around cost control that are being discussed, but that's the biggest difficulty in healthcare right now, is how do you control what is spent?
And this might be a separate issue, but the hospitals might say too that they're not always getting paid back for the services they're rendering.
Yeah, that's becoming a bigger issue because, as you've seen with the Affordable Care Act, right, average deductibles are going up. So an average deductible went up the biggest amount last year by 37%. And it's a little over $3,000 and some change. And then in bronze plans, which is the lowest premium plans, they average around $7,000 a year. And a lot of people don't have $7,000 sitting around. So hospitals are increasingly having a hard time collecting the deductibles from people and things like that. So we're going to hear a lot about that, I think, in the next year or so, about people who are insured, but really aren't well insured because they don't have the money to pay these out-of-pocket costs like deductibles and copays.
And I want to go into that hardship just a little bit more and underscore this. Most Americans covered under the ACA, as I understand it, qualify for subsidies, discounts on the full premiums, or at least some help and some federal support there. But middle income Americans don't, right? Are middle income folks struggling to pay the full premium?
Well, a lot of people, I think I saw something from a conservative publication just the other day, the Paragon Health Institute, that says the average, I think, the median person pays about $42 towards their premium. Now, that's a median, so half the people pay more and half the people pay less. And these are folks who get subsidies. So yes, a lot of people still get subsidies, and yes, a lot of people still get help paying for those plans. But The subsidies just cover your premium. People still have to meet these out-of-pocket costs. And what we saw this year is people shifting to plans that had higher out-of-pocket costs because their premiums are lower. So that's partly why we see that. But yes, subsidies exist. People are still getting a lot of help, except for that group that's over the 400%. And that this year, based on the federal poverty levels that are used to calculate the subsidies, is about 62,600 for an individual, or about 106,600 for a family of three. So if you make $1 more than that, you're not getting any help with your subsidy, your premium. So subsidies, yes, do help a lot of people. I did some stories earlier this year. Remember, we had some initial results showing about 1.2 million people fewer signed up for the ACA this year during open enrollment. And a lot of those folks were folks who didn't get a subsidy anymore. And then since then, we have seen about 3 million more people not pay their premiums. So either they were auto-enrolled and maybe didn't realize the cost, or maybe the cost is too much in their budget right now. But that was a big jump, the 3 million drop. And policy experts and political folks are kind of arguing over what the reasons were for that. Most of the policy folks say it's because costs went up so much, that 58%. Remember that people are paying on average about 58% more this year. Some of the administration officials are saying that drop off is mostly due to fraud control efforts in the Affordable Care Act. So there's that debate that's ongoing right now.
Let's lock in on the important work that KFF does, because it does involve scientific evidence / research. You guys surveyed adults covered by ACA marketplace plans in late 2025 and again this year, as I understand it. What did you all find?
So yeah, KFF Health News is an operating division of KFF, and KFF is a policy group, and they do a lot of polling. And their polling is very interesting. It shows that Americans really are deeply worried about healthcare costs. It's right up there right now with gas prices. And, we all know what's kind of going on with gas prices. So something like 64% of folks are very worried about being able to pay their bills. And then when they dig down into it, they look at, who is this resonating with mostly? And 9 out of 10 voters overall say healthcare will influence their decision of whether to vote this year and who to vote for. But when you dig down into it, the Democrats are more likely to be spurred by this, by something like 72% of them say they are. Independents, which are going to be a key factor in the midterms, say that 63% of them say healthcare costs are going to influence their decision to vote. And among Republicans, it's about 47%. Democrats tend to have an edge on voters' minds in terms of which party might do better in controlling healthcare costs, whereas Republicans have the advantage of which party voters think will solve fraud and waste problems. So that's why you're going to hear a lot of discussion from the Democrats about healthcare costs and a lot of discussion from the Republicans about fraud and waste in government programs, which would include the Affordable Care Act.
So you're getting to the affordability problem there without talking specifically, I guess, about the Affordable Care Act. Let's talk about other things like employer-sponsored insurance or Medicare, other types of coverage. They facing these same kind of pressures too?
Yeah, we're seeing costs go up kind of across the board. And again, remember, it's a function of prices and how much is being used. And when they combine, that's what you get national health spending on. And it's always been going up. It's generally going up faster than inflation. Why is that? It's, we have an aging population. We have growing labor costs. We have new drugs and treatments. The new weight loss drugs are a factor in why are we spending more? Because we're spending more on some of these drugs. But on top of that, we've also got this year the Affordable Care Act, right? We've got premiums going up partly because those subsidies went away. The insurers said they partly raised premiums by about 4 percentage points of that additional increase this year because they figured there's going to be fewer people in their coverage. And the people that drop out tend to be people who are healthy. So that leaves them with sort of a sicker pool. So they have to price that in. So those costs go up. We're seeing hospital costs go up. All of these things going up. So it's a function of all of those things that are kind of being rolled into these premiums. And then that affects how both employers, because employers are paying more, and individuals are seeing what happens with their costs.
To really contextualize this conversation with some background on, first of all, what generally drives health insurance costs to go up, and then help me understand if there's any kind of policy levers that could be pulled to sort of address the issue, to address the rising costs.
Yeah, that's the $64,000 question. Ever since I've been covering healthcare, it's been, how do we control these costs? And again, we spend about 31% of our healthcare dollar on hospitals. Physician services about 21%. And then like a lot of other things, medical equipment, home care, administrative costs are about 24%. So that's kind of your pie. So where do you pull the levers? And so more and more focus is a lot of focus is on the insurers, right? Everybody kind of blames their premiums going up. Oh, it's those insurers, right? But what feeds into that are hospital costs, drug costs. So we are seeing some changes. I mentioned the effort in Indiana and some other places to kind of cap what people are paying for, what hospitals can charge for their services. We've got also now there's some negotiation in Medicare over drug prices. We're seeing some other efforts around drug prices a little bit on the margins. How are we going to control those prices? We pay the most in the world for drugs in the United States compared with other countries. There's been a little bit of discussion about price controls, but it's always been resisted. So what else can be done? Sort of big picture, national policy level, people are looking at consolidation as more and more hospitals consolidate and then they buy up doctor practices. They've got a big negotiating tool with insurers, right? They can say, look, I've got all the doctors in this area and most of the hospitals. If you want me in your plan, you're going to have to pay me more. And insurers are consolidating and trying to fight back and saying, well, if you want our business, you're going to have to lower your prices. So one area that some policy experts say should be focused on is this consolidation, but that's tough. It involves antitrust and fighting mergers and things like that. So that's like one big picture thing. What are some of the smaller things? Maybe the more band-aidy type things would be these caps on prices. How much can you charge? Can you limit it to 2 times Medicare? We're seeing some states try that with their state employee programs. And then we're seeing some employers try that as well. Maybe we're only going to pay 2 times Medicare for this, take it or leave it. But again, it depends how much negotiating power do they have with those hospitals and doctors. So those are kind of big picture national policy type questions. You may also want to know what kind of like individuals can do, and that's a little more limited, but we could talk about that if you would like.
Yeah, really quickly, if you can.
Yeah. So a lot of folks say, hey, maybe you can switch to generic drugs. Maybe you can choose a plan that has maybe a higher deductible and a lower premium if that's your concern. But if you're having trouble making those deductible payments, choose one with a lower deductible and higher premiums, perhaps. Most importantly, I think from a lot of the coverage that we do at KFF is if you have insurance, try to stay in network, really double check that because people pay a lot more when they go out of network. And those are some things that just individuals can do. And then the other thing that individuals and some employers are doing is trying to look at overall prices and maybe shop around. Maybe that MRI you need is cheaper at one facility than another. And some insurers have that on their websites. You can look that up. There's also some cost tools you can Google online that might show you what are the average prices paid. And sometimes it's even specific prices paid at different hospitals and different clinics. And some, shopping for those things that you can shop for might be a way to save some money.
I want to finish out with this. I think this is very important to get a feel for how what's happening federally, federal policy, how that's effectuating the people. Do we have evidence that rising costs are changing how people use healthcare? Are more Americans delaying care? Are they skipping the appointments or avoiding prescriptions because of the price? What do we know?
Certainly people tell pollsters they are avoiding that. And then there's been some studies over time that when people have high deductible health plans, meaning they have to pay a lot up front before they get coverage, they tend to use less coverage. Now, proponents of that say, well, maybe they're just using, maybe they're being smarter shoppers and maybe they don't really need to go. But a lot of folks say, you know what, they're skipping care. this can be a real problem because if you skip care and you put things off, it could be a lot worse when you finally do seek out care, and worse for you sort of physically because your condition may be more advanced, but also worse because it's going to cost more to treat. So I think that the concern is, if rising prices keep people from getting care, if rising premiums cause more people to become uninsured, what is going to happen? And will it drive up costs for everybody as a result?
You've been listening to Julie Appleby, senior correspondent at KFF. Julie, so great to have you on the program. Thank you for your work at KFF.
Thank you.
From Connecticut Public, this is the Wheelhouse. I'm Frankie Graziano. After the break, we go local. How shifts in Obamacare are impacting Connecticut's residents. Have your health insurance costs gone up? How's that impacting you and your family? What are you thinking about that next appointment or the next prescription? Give us a call, 888-720-9677, 888-720-9677. There's more Wheelhouse next on Connecticut Public. This is the Wheelhouse from Connecticut Public Radio. I'm Frankie Graziano. Healthcare costs are eating up a bigger share of many family budgets. Premiums, deductibles, prescription drugs, and out-of-pocket costs have all become part of a growing affordability conversation here in Connecticut and across the country. This hour, we're looking at what Connecticut residents are saying about the cost of care. Joining me now is Katie Govala. Katie is Connecticut Mirror's health reporter. Thank you so much for being here.
Thanks for having me.
Thank you for inspiring this conversation with your work. Kathy Unger-Holt is the healthcare advocate for the state of Connecticut. Kathy, thank you so much for coming on here today.
Thank you for having me.
So happy to have you both on. Want folks to call in. Thank you for listening to the Julie Appleby interview. I want your follow-ups to what she had to say and what these two will have to say to me in a short minute here. Have your healthcare costs gone up? Are you able to pay your premiums or out-of-pocket costs? Whatever. Hit us up, comment on our YouTube live stream, or give us a call, 888-720-9677, 888-720-9677. Going to bring the discussion surrounding the Affordable Care back to Connecticut. How are state residents, Katie, enrolled in ACA health plans faring right now?
Yeah, so I recently did an article. We went and asked Access Health CT about the number of people who have failed to make their premium payments in 2026 and as a result lost coverage. And that number was 22,000 Connecticut residents. And that is about a 75% increase over the number of people who lost coverage last year. And it's true, not all these people necessarily now are going without coverage. So Access Health does this survey every year called a leaver survey, and they talk to people who have rolled off an Access Health plan. So they talked to about 500 people who had coverage last year and don't have it this year. And what they saw was that about 60% of people said that they had enrolled in some other coverage, which is great, but about 40% of people said that they no longer had any coverage at all. So that we care about that 22,000 number because of the 40% of people who now no longer have coverage at all.
In your coverage of the topic, I'm wondering that, because I noticed that you said overall ACA plan enrollment has remained steady. Mm-hmm. How is that when more than 22,000 people lost their coverage in Connecticut?
Great question. So, as the year is going on, Access Health continues to get enrollees. People change jobs, move into the state, have an opportunity to enroll in a plan. So that means they are continuing to see people enroll in plans, which is a good thing. But again, I think that initial number of people who have rolled off plans who now no longer have coverage is still a group that policymakers are concerned about.
You heard us talk earlier with Julie about enhanced premium tax credits and them lapsing last year. That was a large driving force in the United States government's shutdown earlier this year, of course, the longest in history. But state officials did step in to try to lessen the blow for Connecticut residents, right, Katie?
Yeah, that's right. And Connecticut was one of only a handful of states that did this. So Governor Lamont set aside $115 million that went towards helping some of those people who lost enhanced subsidies get that help back. So for the poorest folks who lost those enhanced subsidies, people making between 100 and 200% of the federal poverty level, that money went towards replacing everything they lost from the federal government, so they see no change. And then you heard in the last segment, people making over 4 times the federal poverty level lost all their help. So the state said, if you're making between 4 and 5 times of the federal poverty level, we're going to replace half of what you lost. So, that is help that the state gave, and only, I think, about 10 states provided some sort of support. So Connecticut was definitely a leader there.
So I guess it's good to live in Connecticut and good to work in Connecticut, I guess, Kathy. So I'm going to turn to you now and dig into trends you're seeing in your office. But first of all, for anybody who isn't familiar, would you tell us what you do and why it might be hard at this time?
Oh, thank you. Yes, I am the healthcare advocate for the state of Connecticut, and I run the Office of the Healthcare Advocate, which is a state agency. We help people with all things health insurance. So that includes helping people find health insurance, choose the best health insurance for them if they have options, looking at educating people about their health insurance plans, being able to understand what their coverage is and what it pays. Every health insurance plan is different, and the criteria that's used by the different health insurance plans is also different. And we help people with any kind of obstacles to using their health insurance. So that includes being denied prior authorization or being denied a bill or a claim. So we have attorneys, nurses, paralegals, other experts in our office that will help people for free, all residents of the state of Connecticut, to make sure that their health insurance is paying when it should. And then we use our experience with about 6,000 consumers every year to look at the patterns and trends that are happening in healthcare and what we can do from a policy level, what we can recommend to our state legislators and the governor to fix some of the problems that we're seeing on a systemic level.
Your job also puts you on the board of Access Health, right?
That's correct.
So help us understand how many people would be on the ACA marketplace plans in Connecticut. And then if you could somehow contextualize that versus insurance plans the rest of the way in Connecticut.
Sure. So there are about 150,000 individuals in the state of Connecticut. Just to put that into context, that's about 5% of our population. And before the Affordable Care Act, that was 5% of people who didn't have access to any type of health insurance. Anytime you can increase the pool of people who are insured, it makes it less expensive for everyone else. The other very important thing that happened with the Affordable Care Act was prior to the Affordable Care Act, people were waiting to get health care. They were coming onto programs like Medicare much sicker. And after the experience that we've had with the Affordable Care Act, we see how much it's relieved the pressure on the Medicare program. And so many people are coming onto Medicare much healthier than they otherwise would have been.
So you're saying that there is a positive aspect to getting this kind of insurance. You're saying that it does make Americans healthier.
Yes, absolutely.
Let's go beyond the ACA for a bit, though, because obviously, as you said, there's only 5%, so there is more to talk about here. Anecdotally, what are you hearing? Because I know you're saying people are calling you, and I'm familiar with your work because I used to work with one of your predecessors before. So what kind of anecdotes can you tell us about?
Well, certainly the biggest issue is that people have been calling more panicked, much more in despair about their health care and telling us, well, I have insurance. Why do I get a bill? Why is this bill so high? So we're hearing a lot of issues of people just almost giving up, almost feeling like they have no control. And people will say to us, I'm just one car accident, one house fire, one diagnosis of cancer away from being completely ruined. And it's a terrible place to be. We're also hearing just generally about the types of issues where the insurance companies are using artificial intelligence more to deny claims and to examine prior authorization. So we're having to intervene on their behalf. And we know we only see a tip of the iceberg. It's a very small a pattern of what is happening in healthcare, but the delays that the insurance companies are putting forth are very concerning to a lot of people.
Any positives, though, in terms of actually being able to talk to a real person like yourself or anybody you work with? Because I think about that now, and the prior authorization process, that initiates a lot of people to their health insurance, I would imagine, whether they're trying to get on a GLP-1 or they're trying to get some kind of medicine. That's when they, some other kind of medicine, that's when I'm sure they get initiated to it. So, and then you talk about AI and the way that these health insurance companies are. That's been a big topic of conversation in America, of course. So anybody happy to talk to a real person within your office there on Capitol Ave?
Oh, sure. So one of the things that we know statistically is only about 1% of people who are denied prior authorization or payment of a service appeal that denial. So we are encouraging everyone to examine the explanation of benefit statement they get from the insurance company, the bill they get from the doctor or the hospital, and to give us a call if they don't understand why they've been denied. Because 70 to 80% of the time, our office can get that denial overturned by talking to the insurance company or negotiating with the provider.
Can you talk to me, Katie, about Medicaid? What's the situation that we're in right now? Because I think that the new rules for Medicaid in terms of work requirements go into effect 6 months from now?
Yeah, that's right. But before I answer, I just want to say, the work that your office does is just so incredible. And I think, I spend a lot of time talking to policymakers, but Kathy and her team are really, they're hearing directly from people. It's almost like what we should be paying attention to 3 months from now instead of what we're paying attention to right now. So, that office and the work you all do is just incredible. And yes, round of applause. And so, yes, we are getting new Medicaid rules in January. And what's going to happen is that people are now, for the first time ever, going to have to prove that they meet what's called a community engagement requirement. So this is for people on Husky D. So these are low-income adults with no children. They're going to have to prove that they either, work, go to school, do volunteer for 80 hours a month, and in order for them to qualify for their Medicaid. Or they have to prove that something is preventing them from meeting those requirements, and then they don't have to prove that. So another big change that's coming is right now people get quote unquote redetermined or reassessed for whether they're still eligible for Medicaid one time a year. And now that's going to go up to 2 times a year starting in January. And basically what all of that means is a bunch more paperwork for people. And so what studies have found when certain states have put work requirements into place is not that people no longer qualify for their coverage, but that they have a harder time proving they qualify and lose coverage as a result. And even before January, we're going to see a smaller population lose access to their Medicaid. So in October, people who currently qualify for Medicaid with certain immigration statuses, like refugees, asylees, people with temporary protected status, they're no longer going to qualify for Medicaid. So the big changes are coming in January, but we do have a smaller but very significant change coming in October as well.
You've worked in the healthcare space, as I understand it, Kathy, for 40 years now?
That's correct.
So when we zoom out, can you shed some light on how the healthcare space has changed over the past few decades and how we got here? Because it sounds like the goal of the Affordable Care Act, and at least what lawmakers worked out, was to get more people insured or to get healthier by the time they needed Medicaid. So help us understand.
Yeah, thank you. To Katie's point, let me just add that one of the penalties that also comes with Medicaid is if you no longer qualify for Medicaid, you can't qualify for care under the Affordable Care Act. That's one of the provisions in the bill. So that makes it even more concerning. Just to talk about a little bit about my history in healthcare, I won't go back too far, but my family was very involved in service industry, teachers and nurses, and I decided that I wanted to do something similar. So I went into healthcare management. At the time, the University of Connecticut had a program in healthcare management. They no longer have that program because healthcare is treated much more like a business now than it is a service industry. So 40 years ago, you would see all the hospitals coordinating with each other, collaborating with each other, making sure that people at a local level could get the care that they needed. And then if you needed something more significant, then you would go to one of the regional leaders that would have would be able to serve more complicated issues. We are currently losing so many local services through the consolidations that have been happening in Connecticut. And, as Julie talked about on the earlier segment, there's so much to be done about what has been happening with healthcare and how it's leading us to where we're at right now, where everything is fractured. You have insurance companies that are making their money. You have hospitals that have consolidated, and frankly, they have eaten up all of the mission-oriented service delivery aspects. So it's been a big change.
Sounds really bleak, to be honest with you, and that's we're glad to hear the honesty because people need to know what's happening. But I mentioned how you worked in the healthcare space for 40 years. A big fan of our show is also a former healthcare worker. Betty Jenkins Donahue, a retired nurse, she reached out to us actually through our election survey, which you can all fill out right now in advance of the midterms at ctpublic.org/election, ctpublic.org/election. In a recent interview, she told me she's dedicated to advocacy on the healthcare front, despite her being on her husband's insurance and not needing it anymore. She's from Voluntown, small town in southeastern Connecticut. If you don't know where that is, that's on the northern edge of New London County that borders Rhode Island.
I live in a town where there is no public transportation. I live in a town where the closest healthcare provider is 20 minutes away. We have a 25-minute ride, at least a 25-minute ride to our closest hospital, and the hospital which I go to is 35 minutes away. We have no pharmacy in town. We have no dentist in town. So I think our state and local representatives also need to be encouraged and advised that transportation in rural communities needs to be addressed.
Betty said that she wants lawmakers to commit to healthcare access, including transportation to and from her provider, and continue to provide support for healthcare insurance like ACA, like Medicaid. She said she's already heard from the CEO of a local community health center that they may have to cut services because there may be fewer payers with all the federal healthcare policy changes. Payers are basically insurance groups and other entities that reimburse health providers. Betty also said that healthcare reform comes down to political action in her view.
I don't feel that our current administration is willing to work on improving healthcare insurance and access. I do feel, however, that our federal representatives are committed to improving healthcare, and I think we need to continue to put pressure on our federal representatives to keep the heat on the current administration.
A big shout out to Betty and her husband out there in Voluntown. Thank you for continuing to listen to the show. Big radio hug out to you all and participating, because this is what we talk about when we talk about civics. You want people to talk. You want people to share their thoughts. She's a retired nurse who lives in Voluntown, as I said. Any comment, Katie or Kathy, on what she said about access to health care in her small town, or about the idea of advocating for health care access during this campaign season above other issues?
Yeah, transportation is the biggest reason why people don't access healthcare. Studies have shown that over the years. And so there are a number of community organizations that operate out of the Norwich area that will provide transportation. So I would suggest that, that folks that are in that situation where transportation is an issue, look into that because there are some things that are being addressed through that.
This is the Wheelhouse from Connecticut Public. I am Frankie Graziano. After the break, we're going to continue our conversation about healthcare affordability in Connecticut, including what residents are telling the Office of the Healthcare Advocate. Questions on what you heard so far, hit us up on our YouTube stream. Give us a call, 888-720-9677, 888-720-9677. You're listening to the Wheelhouse on Connecticut Public. This is the Wheelhouse from Connecticut Public Radio. I'm Frankie Graziano. For many Connecticut residents, the cost of healthcare isn't just a personal concern. It might be political. As candidates make their case to voters this election season, where does healthcare fit into that conversation? And what are people across the state hoping to hear? Still with us, Katie Govala, health reporter for the Connecticut Mirror, and Kathy Unger-Holt, Connecticut's healthcare advocate. Katie, peer into the crystal ball here. If folks want to give us a call, by the way, 888-720-9677, but be quick because we're almost done. Katie, let's peer into that crystal ball I was talking about. You follow this year's state legislative session in Hartford, so you're aware of the support advocates and healthcare consumers are asking for. What topics do you expect the state legislature to talk about, particularly with those rules coming into effect? Were they able to capture some of those requirements, or in terms of the people that might go off of it with the money that they got a couple of years ago, or will they still need to do more work, do you think?
Peering into the crystal ball never got anyone in trouble. I expect that as, there's so
What's
much.
the journalist in you looking forward to,
there's,
right?
There's so much about these Medicaid rules that state policymakers still don't understand. So, for example, there's a term called medical frailty that if you can prove you have medical frailty, you would be exempt from those work requirements. But the federal government put out rules, I think, last month that took state Department of Social Services by complete surprise, and it's actually going to require a ton more paperwork to prove that people are exempt through that medical frailty. And so, DSS has said there is no state that is prepared to do right now what the federal government is requiring them to do. So my guess is that as some of these changes roll out in January, we will hear from state agencies and state legislators who are talking to their constituents about needs to address some of the problems that come up. And I think another thing we're going to be hearing a lot about, if the governor wins his reelection campaign, is the Connecticut option. So that is something that he and his administration have been talking a lot about, studying a way to create a plan that any Connecticut resident can enroll in. And Sean Scanlon, the comptroller, who's does a lot of healthcare work with the governor, has committed to legislation next year. So in 2027, that doesn't mean the Connecticut option will come in 2027, but we will see legislation that tells us how the state is thinking about designing that plan. So those are the two conversations that I think I'm most interested in, that I expect will happen next session.
What you don't do in the summer, Kathy, is head over to the Capitol and provide testimony in a public hearing. So that's something you might do in the winter as we have the next legislative session. What might you be preparing to ask of lawmakers, or something that you asked last session that didn't get done that you still need here? What do you think?
So we have a number of proposals from the Office of the Healthcare Advocate, again, based on our experience with consumers. We need more standardization in insurance. There are so many types of insurance. If we could get some rules around clinical standardization so that every policy doesn't require a different set of circumstances for each different type of illness or injury. That's a big thing. There's a lot of churn in healthcare, and what that means is people tend to gravitate to other health insurance plans over time. On average, people have 20 to 30 different types of health insurance over their lifetime. One of the things we'd like to see is if you've been approved for a procedure under one type of insurance, when January 1st comes, that approval goes with you. You don't lose that approval and have to get it from a new insurance company. There's a lot of inefficiency in healthcare. One of the things we'd like to see is this constant requests for prior authorization for people who have chronic impairments that have shown that they're not going to change. Their health issues are not going to change.
Every month you're having to get prior auth for something.
Exactly. So there are people we help. There's been just recently a 19-year-old and a 39-year-old who have significant disabilities whose condition never changes. Every 6 months, they have to show their insurance company that it hasn't changed, and every 6 months, they get denied. And then they come to us at the Office of the Healthcare Advocate. We fix it and wait another 6 months. So if we can eliminate some of those types of inefficiencies and standardization problems in healthcare, then we can move some of these cases forward a lot easier.
Early in the show, Julie Appleby from KFF Health News offered some advice for people who could no longer afford health insurance through the Affordable Care Act exchange. What else can you offer listeners?
So one of the things I would say is look at your total costs of healthcare. Speaking of not having a crystal ball, we don't necessarily know what our healthcare needs are. But if you do, if you have a chronic impairment or an illness, and you know you want to see particular doctors, make sure they're in your network. Don't just look at the premium cost. Consider the entire cost of healthcare. If you know you're going to need pharmaceutical assistance and other types of care, then make sure that it's covered, and definitely take advantage of all of the things that come before a deductible. So if you're entitled to a wellness exam, go to that wellness exam. What you don't know can hurt you. So you want to attack as many of the issues that you have to deal with in your healthcare as quickly as possible up front. Well, we also do a lot of work in my office with medical debt and helping people to understand how to reduce medical debt, how to avoid medical debt. And we're developing some new screening tools now that will help people to be able to get hospital financial assistance where they can get free or discounted hospital care if they qualify.
So there's a lot of buzz terms we talked about here as we finish up the show, and there's a lot of things like prior authorizations and all kinds of issues to navigate. Where can people go to get help?
Well, they can certainly come to our office.
How do they reach you?
Well, we have a great website with a lot of resources on it, a lot of self-help information, but also information about how to contact us. So our website is the Office of the Healthcare Advocate in the state of Connecticut. It's kind of an odd address, but if you Google that, then you'll find us.
You've been listening to Kathy Unger-Holt. She's the healthcare advocate for the state of Connecticut. Kathy, thank you so much for being here.
Thank you.
And my friend Katie Govala, Connecticut Mirror's health reporter. Katie, thank you so much for joining us.
Thanks for having me.
And thank you for the inspiration for the show. And before we go, folks, I got a reminder for you about our election survey, which listeners can fill out ahead of the midterms to inspire what we cover at Connecticut Public. Like commentary we got from Betty Jenkins Donahue, who's a good friend of mine. We want to hear from you. Find the survey at ctpublic.org/election. Again, that's ctpublic.org/election. Today's show, produced by Chloe Wynn. Thank you to our interns, Amanda Adams and Katie Service, for helping out as well. It was edited by Eric Austin. Our technical producer is Dylan Reyes. I want to thank Tess Terrible, our talk show unit, visuals and operations team here at Connecticut Public. Folks, download the Wheelhouse anytime on your favorite podcast app. I'm Frankie Graziano. This is the Wheelhouse. Thank you for listening.